quick housekeeping things before we get started. First off, I just wanted to thank the co-chairs of the Fairfax Reentry Council, without whose support this wouldn't be possible, Leanne Hanna and Tia West. Thank you to our sponsors, VPPA, for their generous contribution to this event. And again, thank you so much to our panelists. If you have any technical issues at any point during the session, please feel free to put them in the chat. I'll do my best to respond to those as they come about. If you have a question for our speakers at any point, please place them in the Q&A section of the chat. The panelists will go through and they'll speak. They'll all speak, and then there'll be a time at the end where we can have those questions be answered. And so that's the way the format will be for today's session. Just as a reminder, this is the second panel of a series of 8 webinars this month. And so we hope you visit our Eventbrite page and sign up for those that are still remaining. We have some fantastic ones on deck. So, and the PowerPoint slides from today's presentation will also be provided. With that, I'd just like to go ahead and just give a brief introduction for each of our panelists, and then just turn it over to them. We'll go in order of when they're speaking. I'd like to introduce Nhat Nguyen. Nhat arrived in the United States in 1975 as a Vietnam War refugee. He received his undergraduate degree in clinical psychology from the George Mason University and his master's in social work from the Virginia Commonwealth University. He currently works for Fairfax Community Services Board, working as a clinical supervisor with adult behavioral health outpatient services, providing substance use and mental health co-occurring disorder treatment. So thank you so much for joining us. The second person I'd like to introduce is Judge Penney Azcarate. Judge Azcarate is on the Fairfax Circuit Court, where she provides over all matters, including civil, family, and criminal. In this capacity, she implemented a new veterans treatment docket to assist combat veterans with mental health and other substance abuse issues, the first such standalone docket in Virginia. She currently chairs the Supreme Court's Veterans Docket Advisory Committee. In 2019, Judge Azcarate established the Fairfax Circuit Drug Court. Prior to being appointed on the bench, she was a senior associate at Briglia and Hunley, PC. She received her BS in criminal justice from Old Dominion University. Upon graduating, she was commissioned in the United States Marine Corps and served in Saudi Arabia during Operation Desert Storm. She earned her JD degree from George Mason University School of Law. Next is Lanier Yee, LPC. She is a drug court coordinator and behavioral health supervisor. Lanier started her career working in the criminal justice system. She interned in the jail with Arlington County Department of Human Services, spent some time with the SMI population in residential, then went back to Arlington County, where she played a key role in the enhancement of their drug court program. During that time, she continued to work in the jail, but was focused on developing the treatment and providing quality services for drug court participants. Prior to coming to Fairfax Drug Court as a coordinator, she has been working in the drug court field for almost 4 years in the role of a case manager and role of primary therapist. She has a passion for accountability, courts, and results, and she has seen firsthand for themselves. She earned her bachelor's degree in psychology from Miami University of Ohio. She obtained a master's in forensic psychology and a master's in clinical mental health counseling, both from Marymount University, and she holds a certification as a national certified counselor and licensed professional counselor in the state of Virginia. Outside of work, Lanier has obtained a certification in sports nutrition and is certified as a group fitness instructor. Aside from being a busy mom of 2, she enjoys fitness. She is a certified spin instructor, loves lifting, and tolerates HIIT training. Last but not least is Derwin Overton. Derwin Overton is Executive Director of Opportunities, Alternatives, and Resources, also known as OAR. Prior to working for OAR, Derwin was an assistant director of Embry Rucker Community Shelter, director of the California House Bureau of Rehabilitation. Derwin is active with the Northern Virginia Human Services Coalition, Fairfax County Network Against Family Violence, Fairfax County Criminal Justice Advisory Board, the Prince William County Fatherhood Initiative, where he's the chairman, Loudoun County, Prince William, and Fairfax Reentry Councils, the NAACP, and Virginia Offender Transition and Reentry Coalition. So we have a fantastic panel here today, and I will turn it over to Nhat.
Great. Thank you so much for inviting me, and I hope I do justice to the panelists here. I'm so honored to be part of such an esteemed group here. All right, so I'm just going to do quickly an overview of what our CSB Community Services Board, Fairfax County, and the City of Falls Church and Fairfax. So I'm going to do a screen share if I may. Make sure this is right. Vincent, great, excellent. All right, so again, my name is Nguyen, and I am a clinical supervisor with the Adult Behavioral Health Outpatient Program. I'm just going to review quickly what we had to respond to, or how we had to work with the pandemic. So I want to just kind of give you a quick timetable of what we had to deal with. Just as a recall, I mean, I know it seems like a long time ago, but with regards to COVID or the coronavirus, the first case was identified in December 2019, and that was in China. The first case that was in the US was identified in January 15th of 2020. The World Health Organization declared a public health emergency in January 30th of 2020. And then in Virginia, we saw our first COVID case on March 7th, 2020. And then shortly thereafter that, World Health Organization declared a pandemic March 11th, 2020. So you can see the timetable is accelerating pretty quickly. And so in response to that, as a CSB, we had to try to keep up. And this timetable just wants to give you an illustration of what we had to do to try to make that happen. A lot of our services, if not all of them, were actually in person. So we had very little telehealth or virtual telemedicine protocols in place. So in less than a month, we had to put something in place that we can continue to provide services for our individuals the best that we can, while still maintaining safety for our clinicians, our staff, and the individuals that we're serving. So as you can see from when we did it, let me just go back to the previous slide. So March 5th was when our executive director provided some updates with regards to our CSB response. And I try to parallel this with the school system because a lot of us might also be parents. So we also know the timetable that the school system had to go through in preparation for their students and teachers as well. So throughout March, like I was saying, it's very accelerated. So within, you can see there, a 12-day span, less than 2 weeks, we had to cancel services and start putting in protocol to address the COVID pandemic. And then by March 17th, we began acquiring or putting in requests for cell phones and laptops so that we can really make our workforce more mobile. And then moving forward to where we are, we had to terminate or suspend all of our services, all of our IOP or intensive outpatient program, all of our case management services went to telehealth. It was easier to implement our case management services to telehealth because we could do a lot of that by phone. We didn't need Zoom or anything like that. So in the background, we had to get the Zoom license. We had to make sure that it's HIPAA compliant and it had to comply with 42 CFR. So all these other moving parts we had to make sure was coordinated properly. Okay, so before COVID, this is what we were doing. All of our services were in person. We were providing group therapy. We were doing individual therapy. We had monthly meetings with clients. We had bi-weekly meetings. So everything we were doing were in person. We were collecting urine screens, doing breathalyzer tests. We were able to address any kind of withdrawals or intoxication issues. If they were coming into our service and they were under the influence, we would be able to pull them out of our group or set them aside so that they can actually call detox, do a screening, and get them services that they need immediately. We had extra staff on site that were able to lend their hands. So if one clinician was in group, another clinician can come in, and interface with that individual, get them the support and care that they need without disrupting the whole group process. We were able to give them group materials at, right at the moment and all this stuff. Kind of going a little further than just the clinical work, some of the other things that we were able to provide are interpretation services. We had no problems with getting them to our site. They would come, we would be able to talk to them and prep them to what we need. They would provide the services in person. All of our clients, their projects were done in person, and then they had that interaction and be able to kind of provide the feedback right away, as opposed to, if you're thinking about how Zoom is right now, everybody is on mute. So you kind of have to wait for a silent moment to be able to jump in or be called to jump in and provide that feedback. So it doesn't really have that natural flow feeling, right? So a lot of the other things that we missed out is the interactive. We can't do the projects. We can't do hands-on activities like the R1 program. And of course, the most important thing for us, and Lanier can also speak to this a little bit later, but to be able to celebrate their successes. Our clients, the individuals we serve, they've been going through lifelong disappointment. So to be able to celebrate with them small successes, 24-hour sobriety, week-long sobriety, month-long, or completion of treatment, those are big steps for them. So we lost out on that, not completely, but it doesn't have the same effect when we went virtual. And I'll kind of talk a little bit about that later. On this next slide, I want you guys to kind of put in the chat for each of these items, A, B, C, and D. Tell me what you see are problems when we converted from in-person to telehealth. And I'll give you guys a couple of minutes to enter your thoughts. And I'll ask Vincent at the end of the 2 minutes, maybe to read a few off. So the A is Zoom on a phone. B is, of course, Zoom on a laptop. C is a picture of a phone, Zoom, and a headset. And D is a bunch of people sitting around looking at a phone. All right, so Vincent, if you don't mind, can you give me one or two of what the attendance said for item A?
So this is a comment for all three, for A, B, and C.
Okay, sure.
But just kind of like nonverbal body languages aren't there in kind of like A, B, and C. So I think for me specifically, I see problem with B as being a couple of cameras were off as well. So another one says that for A, there may be more people in the Zoom than just the 4 people that you see on the phone screen. So that would be one specifically for A.
And what about D? Did anybody make any comment to D?
Somebody mentioned that D could be a concern, and I think what they might be getting at is just the fact that other people could be that aren't a part of the session could be involved in kind of what might be going on. Right,
and everything that you guys have shared is exactly on point. And this is things that I guess we had a year to really see what the problems are. I mean, when we first came into Zoom, we didn't think or anticipate any of these issues. And we kind of stumbled along and realized, well, we can't really provide the same quality care that we were doing before on a virtual platform because one, like A, we don't know if the other members are showing distress or raising their hand or trying to speak and forgot to unmute themselves, right? B, just like you were saying that, some of the cameras are off, at least we can see 2, maybe 3 persons are not showing. So we don't know what's going on. And, obviously for us, we want to make sure that the participants are there and they're actually paying attention. They're not just signing in and then going off and doing something else and getting credit for attending their session. C and D are pretty related in that confidentiality is an issue and we don't know what else is sitting around or by them or can be heard. So we want to make sure that for us, especially for providing substance use issues or any kind of behavioral health care, that confidentiality is one of the most important things that we protect. Right? So this is where we're looking at right now. So intensive outpatient treatment during the COVID situation, everything that you guys just shared, we were allowing people to participate by Zoom. Again, we were stumbling along, so not everybody had Zoom capabilities on their phones. They may not have a smartphone, they may not have Wi-Fi or internet connection, so they may have to dial in. We had to suspend collecting urine screens because it wasn't safe. We did not have a safe protocol to collect urine screens from individuals. And then when there was an emergency, like we saw in example B, with the persons not being on, we actually had a few situations where luckily their camera was on and we actually did see somebody passing out. And we didn't know they were passing out from alcohol or drugs. So because it was only one clinician running the group, they had to suspend the entire group just to address that issue, that emergency with that one person. Luckily, those situations resolved itself. It didn't end in any kind of death or any more serious situation or consequences, but it was still something that we didn't have anticipated to have the necessary safety protocols in place. Group materials had to be emailed in advance. And again, if we're talking about, do they have access to internet? Can they print these things? If they're relying on their phones, then they're going to have to zoom in on everything and read word by word to try to keep up with us. They can't fill out the blanks to capture their thoughts as we're reciting their project or their group exercise or what have you. For most people who don't know, when we went to telehealth, this virtual remote interpretation is at a higher rate. So it definitely costs us twice as much to have interpreters in place than we did in person. Apparently video remote interpretation, they require 2 interpreters, not just 1, even though it's the same session that you might have in an in-person session with just 1 person. And then virtual presentation, again, if they're just presenting something and the person has a phone, obviously the other members can't see what they're trying to present. So it took a lot longer in terms of providing the care. Some of the forms that we needed, some of the administrative stuff, we needed to have wet signatures, and that required us, well, do they come in to sign these forms, or do we fax it to them or email it to them and they somehow sign it, scan it, and send it back to us? So then we had to get into using another platform, which is DocuSign, to get authorization. So another thing that our clinicians and our admin staff had to learn, and then at the same time, getting the clients to be able to feel comfortable with using that as well. And then the other thing that I put on here is accountability. When we were talking about some people not showing their video, are they actually participating? Are they even attending? So we don't know if they're coming on late, if they're missing out, if they're even there. And we have a lot of clients who's like, yeah, I'm having technical issues. I can't seem to get on at the right time. And that becomes problematic because is it really technical issues, or is it just them, being them, I guess. So those are some of the issues that we were kind of faced with. In terms of what we had learned from this is that minimally, that every participant needs to be Zoom capable, which means we should not allow them to call in. If they are not Zoom capable, then maybe they need to come to our center and use one of the rooms where they can have access to a Zoom device or Zoom capable device to participate in, whether it be in their individual sessions with their clinicians or their psychiatrists, or in their group sessions. We also want to make sure that they're in a private location. So how do we know they're in a private location? Especially now, you see that I have a virtual background. How do you know this is private and I'm not sitting in a park enjoying myself outside doing this presentation, right? That they have a working camera and that their cameras are on. And, if you've ever tried to do a conversation or a dialogue with Zoom, it's usually one person speaks while everybody waits. So we have to learn to be muted until we're called upon. And so that disrupt especially in a group process, it's kind of disrupt the group flow, but we have to kind of sacrifice some things to make sure it works. And then using a headset with a reliable mic. And then of course, minimally, we want to make sure that the individual has access to the internet or a Wi-Fi. What we would prefer is that they have a laptop or a computer with a camera, that they have an Ethernet connection, and that they have a backup device or equipment. If my computer were to die right now or I freeze, I want to make sure I can get on my phone and jump in so that this presentation doesn't just go awry, right? And then if they don't have access to DocuSign, then they have access to a printer and a scanner, and they could send it whatever requested material back and forth. Right? Administratively, some of the things that we also learned is that in our engagement, our outreach calls, we should be assessing that technology. I know we're doing a good job in assessing their ability to attend services in a technological platform like Zoom or Team or whatever platform you might be using, but to reaffirm when we're about to do the orientation that these things they have access to. And then also as we're transitioning from a purely virtual telehealth model to maybe a hybrid or back to in-person services to assess their comfort level to what they are able to do. So we want to make sure that we can help them adjust as we adjust our system of care as well, okay? To be able to send an orientation packet early so that when we do the appointment, the orientation appointment, that everything is done. We don't have to slow down the process of them starting in treatment or services with us, using DocuSign, as I mentioned earlier, and to be able to get the communication so that we have wet signatures where it's necessary, as well as other documents that we need verification that they're informed. For example, a TV, our services, even though we were in virtual platform, we still required our clinicians to have TV screening on all of their clients. It doesn't make sense because we're not really in person, but that's one of the licensing requirement that didn't seem to be waived during this situation. So we had to still do certain things that didn't make sense, but it was still a requirement of us. So when we're looking at lesson learned in terms of a clinical practice, one of the things that before we even do anything is to confirm the location. Just so that if there's an emergency and we need to send somebody to that location, whether it be the emergency contact person, 911, rescue, fire and rescue, mobile crisis, whatever, we need to know that they're in a location that can be accessible by somebody else. That we have their emergency numbers, because if they get disconnected or something happens, we need to be able to reach them. And then before we even start their session, we need to assess their risk. You know, are they suicidal? Do they have any thoughts of self-injurious behavior or homicidal ideations? Or if they're under the influence, if they're intoxicated, or they might have withdrawal complications. We want to make sure that we provide more urine screens. And we obviously can't do breathalyzers right now because that's kind of counterintuitive with COVID, and that we don't have the dial-in option anymore. And if we don't have the dial-in option, then we're going to have to be able to work it out that they either are referred to other programs that can support them and have that feature, and or have them come into one of our centers to participate in our virtual platform. And again, of course, confirming their technologies. If we were to go into a hybrid model, some of the things that we definitely want to put in place, as mentioned earlier, confirming locations, confirming their numbers, assessing the risks, is to also consider if, you know, half of the group is coming in or the other half coming in, maybe alternating the participants. So they come one day or half a day, and so that way we don't have 10 to 13 people in a group and the room is not large enough to try to keep that 3 to 6 feet distance. Or we might alternate groups. So the entire group may go one day and virtually another day in person, and vice versa. So, you know, we have to kind of look at what's the best practice to ensure that the service that we're providing can be as best as we can while ensuring everybody is safe. And then do we make it mandatory for in-person attendance? Or if they are supposed to go, you know, like let's say we're doing a flip-flop. One day they're in person, one day virtual. If that one day they're supposed to be in person, do we mark them off as being absent if they're jumping on Zoom to participate? So we have to make sure that the participants are aware of what the expectations are if we are going to be mandating in-person attendance. Of course, in-person attendance is going to also allow us to collect urine screens and have a, be able to put our eyes on them and see how they're doing. And then, of course, I mentioned earlier about maintaining social distance and proper hygiene. So we would want to reiterate that and ensure that individuals have masks when they're coming onto site, have access to sinks and bathrooms so they can wash their hands, and if necessary, wear gloves and such. Okay. I know I'm going kind of fast, so I'm going to take a quick pause right here just to see if there's any questions. Vincent, are there any questions, or should I just keep going?
I would say keep going. We had a great question, but I want to save it to the end to see how everybody will respond to it.
Perfect. Great. Thank you. All right. So in terms of IOP, intensive outpatient program, and other programs in the CSB, and what we had to kind of learn, as well as what we had to adopt and adapt to with our residential partners, our residential treatment programs. So clients who are coming from residential treatment that are being assessed for lower level of care, some of them are being assessed because either they're completed their program successfully or they're worried about getting COVID. So they're asking for an early completion and stepping down to IOP so that they can minimize or mitigate the exposure of COVID. And so we're getting a lot more clients who may not be necessarily at that level of care. So they're still sicker than our typical IOP clients. And so we have to adjust our practice to ensure that we're keeping them sober, keeping them abstinent, keeping them motivated. And that's been a challenge as well. And then going to residential treatment, one of the things when we are seeing that individuals are not making at this level of care, we don't just do like what we normally do in the past, which is we make a referral to residential program, then we close their case, and then they're off to wait for their program on their own. And there's really not a lot of support in place. So what we do now is we provide interim services where they may be referred for residential treatment while staying in our IOP program. And we actually may intensify the frequency of their IOP services so that they see us maybe 5 days a week, not just 3 days a week, while they're waiting for their residential program to have admission for them. If we can't get them into one of our residential programs that the CSB operates, then we may have to refer them to an external provider through their insurance. And we've actually had to do that a couple of times where the wait for them to go into residential was just too long, into one of our CSB residential program was too long. So we actually had to refer them through their insurance, and we know insurance only pays like 28 days or maybe 30 days maximum. But at least that gives them more structure, more support immediately, as opposed to waiting 2-3 weeks before they can get in. And we do this for cases where we know our interim service, our supported IOP, extended IOP, is not going to be enough for them because they're just using every day, or they're putting themselves at high risk every day. So we need them to be in a more structured support immediately. And obviously, this whole reentry thing, conference is really not to try to put them in jail or reincarcerate them just for that purpose, because that's not what incarceration is for. And then we try to supplement what they are currently having by connecting them to other services. For example, we might connect them to psychiatric services for medication management, or we might connect them to office-based opiate treatment, OBOT, for Suboxone or something like that, while they're waiting for residential treatment. Because we're seeing that maybe that level of support will be enough so that they don't need to be rapidly referred to an external residential provider while they're waiting for the CSB provider. Right? And one thing that is of a challenge is all residential programs that the CSB operates. I can't really comment to what the private providers may do or not do, but for our CSB, they have to be COVID-free or negative on their COVID tests within 3 days of their admission. And one of the things that we're learning too is that clients tend to use COVID symptoms to kind of get out of what they need to do. So having this test, having it readily available, is actually going to help challenge those false claims that they may be infected, so that we can still work on their accountability and making sure that they're keeping up to what they're supposed to do. And in terms of IOP, or intensive outpatient program, with our assessment, entry, and referral services, which is also known as our front door. For example, our front door right now, they do only telehealth assessments. So they're Zoom capable. However, many of the clients that they assess prefer to do it by phone. So our assessment has gone from, let's say, 100% perfect in terms of acuity assessment, accuracy of the assessment, to maybe about a 70%, because we can't see the person in person, see the individual in person to assess their psychomotor agitation or retardation, or their distractibility. So their physical presentation is not as well assessed. You guys can probably see me from my chest up, but you can't see my legs kicking or moving around because I'm so nervous, right? You can't see any of that. So those are opportunities that we would lose in our assessments. Referrals to, so the assessment team also does referrals to interim services if they're meeting somebody that they feel like, well, they might be able to do outpatient, but they probably need a little extra support. So they're also making those concessions at the beginning and making sure that individuals are getting either the complementary support in place or going to a program before they come into our IOP program. For example, they may go to detox first before they come to IOP, or they might go to crisis care because they have suicidal thoughts or homicidal thoughts before they come to IOP. So, we want to make sure that we're putting them in the appropriate level to address the acute issue before they come and work on the long-term issue. And I've also noticed an increase in clinical consultations and staffing between our programs. And I really appreciate that, because we want to make sure that the individual that they're seeing is someone that we can manage in our program, so that we're trying to match the right care to the right need, as opposed to just kind of putting everybody where they want to be as opposed to where they need to be. So there are a lot of lessons learned, and we're constantly learning new things as a CSB. At least I'll say from my perspective, we're constantly adjusting what we're doing, because we're always being thrown a curveball. So we're trying to make sure instead of staying behind the 8 ball, we're trying to get ahead of it and trying to anticipate so that we can offer the proper care for the individual, as opposed to trying to see a pitfall and then deal with it then. So we're trying to cover and avoid those potential pitfalls. And with that, I'm going to end. And I know that Vincent said there were some questions. I don't know if it's going to end questions now for me to answer or at the end of all the presentations. So I'm going to stop share and finish my session now.
Thank you, Nhat. I appreciate it. I think we're going to hold all the questions until the end, and then we can just ask, because I think that some might apply to all of the panelists. So with that, I'll turn it over to the Honorable Judge Azcarate.
Thanks, Vincent. I appreciate it. What I'm going to do today is just talk a little bit about drug court. The slides, Lanier is going to go through the slides. What I just wanted to mention, I brought Lanier here because she is the one who has the boots on the ground every day. So she knows everything that's going on with drug court and drug court coordination. And she is the drug court coordinator. But what we have in Fairfax County with our drug court, the drug court was established in 2018. And just to give you a little background about it, the participants in the drug court are people who already have been convicted of felonies, and they are been on regular probation, and they've come back to the court because they are not doing well on regular probation because of either substance abuse issues, mental health issues, or both. So when they come for a probation violation, instead of going to jail, the drug court is an alternative for Fairfax County residents to be able to get into the jail diversion of the drug court, make it through drug court, and if they graduate from drug court, their probation is then dismissed. The probation violation is dismissed, and they can go from there, and their probation is terminated as well. So that's where drug court comes in. We only take high risk, high needs people. So when COVID hit, at the beginning of COVID, the courts were open, but we couldn't have anybody come into court. In March, we had a judicial emergency, so everything was stopped. So for 2 weeks, we didn't have any drug court. In drug court, they come to court every week in the beginning in their phases. So we have drug court every week. So they weren't coming at all for the first 2 weeks. And we had to figure out what to do, because all the services also stopped. So they couldn't, they would begin moved from residential. We couldn't do drug testing. They couldn't have their treatment meetings. Everything had stopped. So what we were able to do is within 2 weeks, we were able to get Zoom up and start having court hearings through Zoom. And that was quite a technical feat to get all the participants. I think there was about 18 or so at that time to be able to get on a Zoom. We had one person who only spoke Spanish. So we had to deal with him as a participant and try to get an interpreter on the phone with him at the same time he was doing Zoom. So we had quite a few issues that we had to deal with. And as time went on, by the summertime, we were starting to bring people back into court slowly. And sometimes we had hybrid systems going on as well. And then we had to work to get everything back up and to start getting virtual treatments. And we would try to do more intense supervision. And we were trying to make sure that everybody was staying alive in the beginning was what we were really concerned about. And then we moved from there. But I wanted to bring Lanier in here so she can talk about all of the great things that we were able to work on, and the she specifically was able to work on to keep people engaged and to make sure we were keeping them safe during this time, but also keeping them accountable. So Lanier, if you want to talk about the specifics of what was going on in drug court during COVID.
Sure. I'm looking a little bit this way because my PowerPoint is on this screen and I'm not really sure how to change it without messing it up. So I'm just not ignoring you guys. All right, so piggyback right off of where Nhat left off, because obviously all of our participants are required to engage in treatment. That's the biggest component of a drug court. It's drug treatment court. So all of our folks are involved in some level of treatment. Most of our folks are in IOP or residential, and they need those two levels of care. Residential stopped accepting new referrals for a period of time. That was really impacting our folks, as you can imagine. And, you know, substance use has been on the rise since COVID for a number of reasons, but they definitely, the substance use went up in drug court. And so the level of care as a result went up to residential. But for a while, we weren't able to do that. So we used some of those interim services that Nhat was referring to so that folks could have something in the meantime while we're waiting on residential to open up to new participants. Now they are currently operating at about a half capacity each program. And I think that discussion is happening often to see when we can start expanding more, because there's still wait lists for people to get in. IOP services went virtual, or still are virtual. There are benefits and drawbacks to that. There's the benefit being you don't have to travel. You know, you can just open your computer or your phone and log in. The drawbacks being a lot of the things that Nhat was talking about, confidentiality issues and not paying attention, not knowing what's going on if they're in a safe environment. We've had less in-person support meetings. So AA and NA meetings, smart recovery meetings, we're not meeting in person. I'm hearing from a lot of our participants that they don't love Zoom meetings. Some of them will go to a Zoom meeting because of the convenience of it. Like, I couldn't leave because I don't have childcare and I'm staying with childcare. And so having that capability can be useful and can still be useful, you know, in the future. But one of the other things that really impacted our participants as far as treatment goes is detox. We use a detox a lot, and they lower their capacity for detox. And then, like Nhat was referring to, we need a negative COVID test to get into detox. So that created a little bit of a barrier. Well, you know, a little bit of a barrier for you and me, kind of a large barrier for our participants. So getting them to have that COVID test 72 hours before going into detox for obvious important reasons. So for the supervision piece, we weren't having in-person meetings with the probation officers. Probation District 29 has changed the way that they are meeting with their regular probationers. For drug court, it's always going to be a little bit different. So I can only speak to what's going on in drug court. But we were not having in-person meetings and doing phone meetings, FaceTime, really getting creative to try to make sure that we're getting eyes on people in some capacity. And we didn't have any home visits conducted during that time. We're still not in a place where we can do home visits at this point, but we are doing virtual home visits for what it's worth, seeing where they're at. As far as the urine screens go, we stopped collecting urine screens for a period of time, and that was my understanding, like, is that was a DOC-wide decision. And then when we were able to, in around May, we did it at a limited capacity. And by June, we were back to 2 times a week, random 7 days a week. So it's been really helpful, I think, for our CSB partners so that we can share with them what the results of their urine screen is so that they're getting the right level of care. And one of the benefits of being in drug court is there is a legal incentive to obtain the right level of care and to follow through with the recommended treatment. So Judge Azcarate already talked about this. I'll just breeze through it. It took us 2 weeks to get up and running. It was very weird. It was very weird at first. And, getting the virtual court started. And then we did a hybrid court for a little while. And the current status is it is in person, but we offer the Zoom if someone is ill or if they have a pending COVID test or, some other emergency that they're not able to come in person. That is approved by the judge. So one of the biggest components of the drug court model is incentives and sanctions. So we're looking at responding to behavior. This is the main kind of the hub of behavior modification. And when you're doing court virtually, it makes it challenging to impose some of the sanctions that we might normally impose. Community service is a common sanction. Well, there's nowhere to do community service. No one's doing anything in person. So we've got to get a little creative. So one of the ways that was recommended by the National Association of Drug Court Professionals is to really emphasize the incentives. And that's what we did. So a lot of the sanctions were calling your PO every day or verbal warnings from the judge. But we really did a lot more sanctions. I created the recovery challenge to keep folks engaged while they were at home doing virtual, and it was like a point system, and you get gift cards for doing the best that week. And I tried to make it fun, and I tried, but it was good. I mean, it got national attention. They published it on the website. It was definitely well received by our neighboring drug courts. Lots of verbal praise. We had Star of the Week. That was generally someone that did the most in the recovery challenge. I would mail out gift cards when I came into the office as a response for winning Star of the Week. You would get to leave early, so sign off of court. Normally we have people stay in the docket the entire time and watch everyone because drug court is very much a cohort, and we want to support each other. And we did a lot of clapping. One of the few things that we can do over Zoom is clap, and then you have the little icon that you can use to clap. We did that a lot, and that was kind of fun, and I think the participants enjoyed it. So the phase progression was not as cut and dry as it usually is when we're in full operation. When we were not urine screening, we could not confirm if someone was sober or not. But I did see the way that they engaged in the recovery challenge. And I did see their communication with their probation officer, the communication with me. So at the end, by July 2020, when we started coming back to court in person, the entire team got together and we talked about, how engaged this person was. For some folks, they were very honest about their use and they told us. For other folks, they hid it the whole time. So we had to kind of come to a consensus as a team how we were going to handle those phase progressions when we got back to court. This is a recovery challenge that I'm very proud of, just so you can see some of the things that I was encouraging folks to do, to include, you know, wellness, getting outside, exercising, talking with your sponsor, you know, Zoom meetings, FaceTiming with your probation officer. So the more communication that you had with others, the more points that you would get. So this is kind of the key takeaways that I think that we as a team took from our COVID experience. Virtual is helpful for some, not for others. I think at this point, a lot of our participants are having a little bit of a virtual burnout, especially when it comes to the meetings. They would really like to be in person. There is some benefit to not having to travel and not having to worry about getting to and from and the time it takes to do that. You know, when you're a drug court participant, your day is filled, top to bottom. So time is difficult. If you're taking public transportation, it takes you 2 hours to get there. When you can just log on, that's a huge benefit. So the ability to have participants join via Zoom or WebEx, I think will be critical to our docket forever, actually, because if someone is ill or they've, you know, broken their leg, getting around is difficult, or they can't get a ride, and they're communicating this ahead of time, then we can set this up, especially if they're, you know, an individual that's required to come weekly, and so that we can, you know, make accommodations for people. As far as accountability goes, it is an accountability treatment court, so that's a big component. It's really critical to continue in full operation. We did absolutely the best that we could, and we got back on track pretty quickly, I would say, compared to some of our neighboring courts, but it really is critical. You know, CSV is still not doing urine screens. We are doing urine screens. So, and that's really important information to know, not just for the court, but it's important for their treatment, having the right level of care. Having the right level of care available to the client is really important. And that, you know, in response to residential, not taking new individuals and it being a little bit challenging to, this person is using, they clearly need to go into detox or residential, but that's not an option right now. So we're doing what we can in the meantime. And how do I keep this person alive, like Judge Azcarate was saying, before we can get them into residential? So that's all I have for you.
Good afternoon, everybody. My name is Derwin Overton. I'm the Executive Director of OAR, stands for Opportunities, Alternatives, and Resources. We're a community nonprofit who provides services for people who've been incarcerated and help them return back into the community. Going last definitely has some of the benefits because I believe that there's a lot of similarities in some of the things that we've been saying thus far in the changes or the adaptations that we've been making in order to start serving people in this COVID world. Today, I'd like to talk to you a little bit about a few things. Our clients and the changes we had to make, the jail, because we began our service delivery model in the jail, as well as working with people in the community. So things definitely changed from that perspective. Best practices and confidentiality, and last but not least, technology. Little backdrop. OAR is currently in a building that is run by Fairfax County. So the agency had no choice when to close, when to stay open, or what we needed to do or not to do. That was very impactful for a couple of reasons. For number one, the day before they decided that they were going to close our building, I was just returning from Trinidad. And that in turn left me very little time to be able to make adjustments. And the first step that we had to do was, of course, follow the standards of the county, which was close our building. That was a great impact to us because OAR and serving returning citizens was very crucial our relationship with the Adult Detention Center was very crucial in our service delivery model. We begin our engagement with people while they're in the jail and then start working with them there and continue that rapport in the community or at our office. Once the jail was shut down, then we lost that ability to develop a rapport with individuals. So it was more of literally trying to catch people as they're being released without any knowledge or information on who's being released. OAR offers something called an after release planning class in the Adult Detention Center. And we do a query of everybody who's within 90 days of getting released. And they would come to that class and we would make them knowledgeable about the services and the things that we can do for them if they weren't already engaged in the OAR classes and services. The other important part as far as our clients were concerned is that the services that we offer were mainly volunteer services. And once this happened, then of course, we lost our volunteers, we lost our ability to be able to serve people in the jail. And last but not least, as everybody's saying, face-to-face meetings had to change. So because face-to-face meetings had to change, it was an important task for us to change our SOPs and how we engage with people. I'm a little old school, and if you told me right now that we would be doing virtual work with our clientele, I would laugh at you and close the door and walk away, because the body language, the affirmations that you get, there were so many things that we weren't getting virtually or on the telephone that we normally got in person. I really never thought that could allow us to do our work and do it virtually. But now I know different. And now I'm thinking that we'll never go back to just all in-person services, and virtual is very important. And as it was just pointed out, one of the main reasons is that some of our clients come from the Route 1 area to come to our office, which is located by the judicial compound. And that's a very long bus ride. If I can meet with somebody virtual and save them 2 hours of their day, which they may be able to use for looking for a job, now they don't need to find daycare. There's a multitude of things that they no longer have to do. I feel like it's making a contribution to the person's lives and giving them a better ability to not get overwhelmed with all the services and the people that they have involved and engage with them. Out of all the entities that presented today, there's a possibility out of the people that OAR works with, they're responsible in answering to everybody who has spoken here today. So think of all the hands and all the individuals that are touching and engaging with that individual. And it's very important from this new hybrid model that we could have in the future on how we minimize that and allow them to use their time to really to achieve things and to move forward. The jail in the community is very important from this perspective. The jail still hasn't allowed access to individuals, and I totally understand why they haven't allowed access to individuals. And that's an important part of our service delivery model. So because of that, OAR was able to take advantage of developing more post-release programs that would happen virtually with the individuals that we serve. However, one of the challenges is the technology piece. I believe before COVID started that the community believed that individuals had more access to technology than they really did. And as we in turn tried to engage with our clients from a technology perspective, we had to learn some very important lessons. Some of those lessons were as follows. When we tried to have our meetings on Teams where we first started, and then we ended up with Zoom, and the individuals who had pay-as-you-go phones were still using minutes to be in the class, and they were using a lot of minutes to be in the class. So are you going to help them with getting more minutes for their phones? Or are you going to say, no, that's your responsibility when you know that people aren't able to get employment right now because of the process of getting employment? So what's more important? Is it about serving and helping the clients and doing what's necessary? Or is it the simple fact that you did something wrong? This is what you have to do, and we're going to require it of you one way or the other. So of course, we had to help people from a technology perspective. We had to do something from the perspective of individuals when they came to OAR, when we were having face-to-face services. We used to have two things that we had for them. One was a snack pack because they may have been released and hungry and needed something to eat. And the other one was a hygiene kit. And the hygiene kit is just the basic items that a person would have, shampoo, lotion, or whatever, so that they can have it, take care of themselves, wash up, or do what they need to do. But then at OAR, we're now finding that there's another need that we need to have, and it's a technology bag that we need to have for individuals. And this technology bag needs to consider a phone or the ability to give them minutes as far as their phone is concerned. And if you're requiring people to do meetings and things virtually, and they don't have a laptop, they don't have a computer, then how are you going to help them to be able to engage as far as that is concerned? What we did find out as far as the agency is concerned is that more people did have the resources than we thought, but we still had to help a large number of them. And we wanted to help a large number of them because some individuals were in turn using their children's technology to do certain things. OAR is a certified batterer intervention program provider, and which is helping people who have been engaged in domestic violence. And one of the things that we learned quickly was having people who have been identified as batterers using their child's laptop in order to attend a batterer intervention program probably wasn't the best thing to do. And I know it was mentioned earlier, but also we had to know more about the background. I love the picture that was put up earlier that was asked about what are the challenges with the individuals in this picture, because I present it from the same perspective. You're in a batterer intervention program, and not every person who commits or is accused or committed because of domestic violence leaves the victim. They're still with the individuals in some cases. And now they're in the same household, and this person is participating in a batterer intervention program. And while participating in this batterer intervention program, it's very important that you sometimes talk about what happened, how you've been changing, what's different about you, what concerns did you have? And if you know anything about these types of programs, sometimes there's victim blaming and other things that may happen. The victim and the perpetrator are in the same household. So it's very challenging to be able to present those type of services to individuals and have them in the household. So that's one of the things that we had to look at and to consider. And I'm afraid to say that there are still some circumstances and situations where individuals are still in the household with individuals, and we're looking for that to change immediately. SOP, standard operating procedures. We had to change our standard operating procedures. OAR is an entity that has a very long hallway and is just all offices, and the case manager's offices were at the end of the hallway. And that meant during COVID time, if you brought somebody in, you have to walk them down the entire hallway to take them down to your office. So because of that, we decided to develop 2 intake rooms. And the intake rooms had teams on the laptops, which allowed us to pare down the amount of people that we had in the office. So we had a 3-team staff that was in the office on a 3-team staff on Monday, a 3-team staff on Tuesday, Wednesday, Thursday, and Friday. There was no commingling of individuals, and that was very important because if we had a COVID episode, we didn't want to have to shut down the whole agency. We just shut down those 3 individuals. So then we had to set up the intake rooms. The intake rooms were a place where we set up laptops, and we would have case managers who were home who would in turn be prepared to do an intake or an engagement with a walk-in or whatever the case may be. But what we also had to do is we had to train every individual in our office on how to complete a walk-in and how to assess a person. And that was very important because the initial assessment on what your emergency and transitional needs are as important so that we can serve you right. And then at a later date and time, we're going to do a full criminogenic needs assessment on you with a tool called the OST in order to determine what were your criminogenic needs and what services do we need to put in place in order to address it. However, one of the challenges of that was, as I said earlier, the classes and the things that we were doing were no longer available. So we in turn had to make an immediate shift and start doing our classes virtual. When we did our classes virtual, we started doing things like MRT, moral recognition therapy. We also had our fatherhood class. There's employment classes to offer. There's doing the carry guides as far as case management is concerned. So doing all of those things were new. And I don't know about you guys, but I'm sure we've all had the experiences of being in the meetings and the person doesn't know how to get off of mute. And they try and try and try and they can't get off of mute, or the system shuts down on them and you're in the middle of the class and you're doing your lessons or you're going through your class and it shuts down. And I sometimes wonder to myself, you see people who come back after the system shut down, but some people don't ever come back. Did that person choose not to come back, or couldn't they come back? And how do you hold them accountable for not completing the class or doing what was necessary because they didn't come back, because you don't know whether it's something that's their fault. I've had so many service outages since I've been working from home, where the entity who provides my internet just didn't have internet services for me. And I literally had to let people know I couldn't attend a meeting, I couldn't do something. Can you imagine if that's with your probation officer, or if that's with the person that has helped you from a reentry services perspective? So to me, those were some of the challenges and the things that our clients needed to look at. we needed to take into consideration the positive actions and behaviors of individuals and what they were accomplishing from the perspective of attending meetings, engagement with case plans, and doing the variety of things that they were doing, just in case that if these things happen, we had other history with them that could point out success or other indicators on whether or not people were doing well. I see we're getting closer down to the time, so I won't belabor this a whole lot as far as what I'm talking about here. But what I will do in a summary as far as things are concerned and moving forward with the challenges, it's very important that we recognize, in my humble opinion, the lack of ability of our clientele to have and to buy technology and to be able to use it. And if we continue in a virtual world of hybrid services, how in turn are we going to be able to serve them hybridly, but also be able to offer them resources to allow them to be where they are from the perspective of having the necessary technology. OAR, making this change, did start studying nursing. I want to say about 3 to 4 years ago, we started studying nursing because we had already had some thoughts about trying to do things from a technology perspective and seeing people virtually as far as it's concerned. But we never really got a chance to implement that, but it gave me a lot of confidence just from the perspective in the medical field. If the doctors are able to see you, then there is the potential of protecting confidentiality and doing things that will allow clients to be able to be seen. But what we had to also figure out is that a mandate on cameras wasn't possible. It was virtually impossible to mandate a person to have a camera. And I find that challenge with my staff, as well as my team, my clients, and everything that we have, because some individuals, for some reason, just prefer not to have their cameras on. So if you're doing a class, and this was also mentioned earlier, if you're doing a class and it's a battery intervention class and the person has their camera off the whole time, are they engaging? Are they participating? What's going on in the background? That's a very important situation, because attending a class like battery intervention, domestic violence, you're making a commitment to the individual that you're serving, you're making a commitment to the victim, and you're also making a commitment to the community, because we want less batterers and we want people to be safe. So in doing that, how can you assure that if you can't see the person or things going on? So we had to mandate the cameras being on, but we also had to have some flexibility. And I think that's the biggest crux of everything that I'm saying is looking into this new world that we're going into and the impact that we had in COVID. The biggest lesson that we learned is that we needed to be flexible. Being punitive with individuals wasn't necessarily going to work because everybody didn't have all the things that they needed as far as that is concerned. Last but not least, as I wrap up this, confidentiality is still of the utmost importance as far as OAR is concerned, and making sure that individuals are located in the proper place. We got working cameras, that our staff has the technology necessary to be able to help people, and that we're as flexible as possible were the changes that we made along with our SOPs. And I think that will take us further along in the future.
Awesome. Thank you, Derwin, and thank you all. I just wanted to pick up on something Derwin had said last. Derwin had mentioned that as a way to kind of help with technological capacity for clients, that they had snack packs to kind of provide for them to be able to do that. I don't know if any of the other panelists would speak about how you address that capacity issue for individuals in your programs, them not having technological capabilities.
I can jump in real quickly. So for us, when we are working with individuals, and I'd actually put it in the chat so that other people would also have that resource, but individuals who have Medicaid are actually entitled to smartphones. And right now during the pandemic, their data plan is unlimited. So they shouldn't have an issue with attending any of our programs. But going back to everyone else's comment, which is, really about having a location that's private or privacy insured, is really the bigger challenge. Because we've had sessions where the facilitator, just because the individual was on camera and just because the individual rotated a certain way, the facilitator was able to see that she was in bed and her partner was next to her. So there's no way there's privacy that we can ensure confidentiality, not of just her, but everyone else that was in the group. So she was actually had to be expelled from that day and then had to be reminded of the importance of confidentiality. So technology we can definitely do. For those who don't have Medicaid or don't have resources that can get a smartphone or Wi-Fi or internet connection, we actually have rooms in our building that are dedicated for individuals to come and use, so that they do have either a laptop or a device that they can connect to their clinician whether it be for individual sessions or group sessions. And it's an office where they can close the door, and we know the privacy is there, and they have access to technology. Now, of course, the challenge, then going back to what Derwin was mentioning, is they would then have to get the old way of getting on the bus or drive themselves to that center to be able to participate. So there's really not, it's almost like when you take away something, something has to give. So it's finding that perfect balance, and we're still constantly trying to find that balance.
Judge Azcarate or Linear, I didn't know if y'all wanted to speak on the technological capacity. It's fine if not.
I mean, I have to piggyback off of what Nhat is saying, because, all of my folks are in treatment and have the same challenges. I will say that we do have a little bit of funds to help support folks in terms of transportation money, gas cards, and smart trip cards. I know for a while the bus was free in the pandemic, and that was really helpful. And now we're kind of getting back to this time where things got to pay again and figure out transportation. But I have food that I give my participants on Thursdays. They come back to my office and get some snacks and things like that. But we have had the phone issue, and I was just able to obtain, I did not know that about Medicaid, which is great to know. But we were just able to obtain some burner phones as well. So to kind of get people by with at least phone calls, if not, being able to do the Zoom capacity. So.
And then another question that came up just throughout you all talking was just the level of accountability. And so how to kind of judge accountability either in classes where people's cameras are off or with no urine tests being available. I guess as you move back into more of kind of an in-person world, are there things that you couldn't do that you're definitely going to bring back just because of that accountability piece?
I would say as far as the urine screen piece goes, we had that little period of time where we were not having urine screens. We have since obtained oral swabs. So I can either drive to their house and hand it to them and have them do it in front of me, or I can mail it to them and have them do it in front of me over Zoom. What we definitely want to have, I mean, that's a large component of a treatment accountability court. So we definitely want to have that in place. And that's something that, should we be in this situation again, or say I don't have a male to observe a male taking a urine, I can give them an oral swab instead.
I think in addition to urine screens, one of the things for us, of course, is going back to looking at the balance of hybrid or in-person, is having them come into in-person sessions. Because I mean, obviously, we can only see two-dimensionally right now with virtual, but once we can have the person in front of us, we can see more holistically what's going on, so that we can assess them better, so that if they're at the right level of care, we can continue what we're doing. If they're not, then we need to identify what we can put in place to ensure that they're going to be successful. This whole shift from in-person to virtual and then probably back to a more hybrid model. One of the things that I have seen is a shift from abstinence-based programming to harm reduction model. And harm reduction works on one level, but it's not going to be one of those long-lasting things. So we need to, going back to a hybrid, may need to look at a balance between a harm reduction and an abstinence model approach.
Great, thank you. And we had a question in the chat just about how your organizations or just the courts responded to how everybody dealt with that uncertainty. So during the time prior to, like, initially when we first started, where everything shut down, the court being closed for having no court for 2 weeks. How was that? I guess how did the people react to that before decisions kind of came down and were made about how things were going to be moving forward?
I think in the beginning, it was hard for not only participants, but the team as well, because everybody wanted to make sure we kept people engaged. And since we had people that did have the high risk, high needs, and they were going down pretty quickly and they didn't have anywhere to turn to. So I think one of the things that was really important was to make sure the team connected well together, and we would have meetings just to figure out what we need to do as a team to get the participants back engaged. And probation jumped up and started having more contact through phones and started getting the technology. Lanier was doing lessons with all the participants very quickly on how to work with Zoom and how to get Zoom on your phones and what you need to do. So it was just making sure we had initial contact to begin with, because since we couldn't do drugs testing, and the accountability piece was tough, and it's still tough now. And some of the ways we're doing it now is to make them come to more court proceedings, that we have eyes on them more often, just to make sure we can hold them accountable. We have them do logs, we have them do journals, all types of different things that we need to keep working on to get back to where we were. But we actually use Zoom as an incentive now too. So if you do really well, you might be able to come to court as a Zoom in a Zoom meeting instead of actually having to take the 2 hours to come to court. So there are ways that we're going to incorporate all this technology in the future as well.
If I can just add to what the judge was saying, I like that idea about using Zoom as an incentive for people. And I could see that incorporated in our IOP, where, maybe using like your model where they start off, let's say 5 days a week, and then they're showing accountability, they're showing really great progress, and then giving them a step down to maybe attending 4 day in person, 1 day by Zoom, and then continue 3 day in person, 2 days by Zoom, and then maybe 3 days in person or 2 days in person, 1 day Zoom. So, we can kind of ratchet it up and continue to reinforce that level of motivation that they already have. But I'm kind of wondering, Vincent, the question that I saw in the chat was talking about how responsive do you believe you were to your coworkers? And that, this is not about the court. So if I can answer that part of the question, in terms of my responsiveness to our team, I felt like, I saw the pandemic as kind of like, the big deal. So we had to prioritize that, and safety of our team was most important. And so even before our executive director made the decision to suspend services, I've already, kind of instructed our team to start looking at calling them and checking in on clients as opposed to requiring them to come in. So that way we can ensure the staff is safe. Because everyone's thinking about that first, as opposed to I need to give care to my client. We're not doctors, so we're not out there putting our lives at risk to ensure that somebody else is alive. So we had to make sure that what we're going to do is going to outlast this pandemic, that we're going to be safe. And then the other thing that we did was we want to make sure, because we were taking on new information, learning how to use Zoom and using different models here, that we had to make sure each team member was comfortable with using Zoom or the different platforms that we were tasked to use. So we were setting up meetings, and I would have them host the meeting. And so they would learn how to schedule, how to host, and how to do things, so that when we were ready to transition to doing clinical service by Zoom, everybody on our team was fully proficient and comfortable, so that the participants coming in won't be stumbling along with our staff members. So that I think helped prepare us to transition throughout the different phases of the pandemic.
The most important thing I will add from our agency perspective and being responsive to the individuals that worked at OAR, I felt like it was important to acknowledge that everybody's circumstances were different. If you're at home living with an extended family, if you're living by yourself, if you got a part-time job at a high-risk place. So I thought it was very important to empower people to be able to make what was the best decision for them in their circumstances and what was going on, because it was impacting everybody different. It's kind of like now with the COVID shot, being out. It isn't important whether or not everybody's had the shot, because we're not changing how we're doing things. We're going to continue to social distance. We're going to continue to wear masks. We're going to continue to do things. And when the person comes to me and says that COVID has impacted me in this way, or they're having challenges because it's stressful, or it's a major change in what they're doing, we had to hear what they were saying and react in a way that allowed them to know that we cared about you, we cared about what you're saying, and we realized this is just bigger than just you and me. It's the whole world, the whole community that's impacting. And it took a lot of time of listening and giving people the opportunity to do what they needed to make them healthy. And I'm very glad that we did, because I never thought that we would be in this as long as we were.
Absolutely. And I know we're over time, so I think that's a great way to end it. I just wanted to thank you all. Thank you all for joining us, and thank you to our wonderful panelists for just giving your knowledge and your lessons that you've learned, and kind of things that we've seen over the past year, and how we all throughout of our agencies can take those lessons and move them forward. So thank you so much for your time. For everybody else, we have our next session next Tuesday, May 11th. Starting again at noon, where we'll be addressing lessons learned specifically from a food perspective. So how people giving out food resources into the community adjusted during this time, and the lessons that they learned. So come back next week to hear more. So thank you for joining us, and we hope you have a great rest of your day.